Good afternoon, ladies and gentlemen. Good afternoon. I'm Paddy Tillett, President of the City Club. Welcome to our Friday forum on the pharmaceutical side of the drugs war. Our guest, Alan Holmer, is President of PhRMA and will present the industry's perspective on why pharmaceutical drug prices are so high and what this means for the future of Medicare. Before we begin today's announcements, I want to welcome two visitors from the Eugene City Club, Don Cayley and Dan Bryant. Would you stand, Don and Dan? Let's give them a proper welcome. It's a very salutary reminder that we're not the only City Club around here. We're taking reservations until 5 o'clock today for our special gubernatorial forum luncheon. That will be held on Wednesday the 1st of May and will be in the ballroom at the Hilton Hotel. It'll feature former Governor Vic Atiyeh and all 6 of the major gubernatorial candidates. Check our website, the bulletin, or call the club office for more information and make your reservations today before it's too late. Join us next Friday, May the 3rd, for a program on philanthropy in Oregon featuring Greg Shale and John Hampton of the Oregon Community Foundation. This is a critical issue for Portland's nonprofits and for the City Club especially, so please come and heed this rather important program. Also next Friday, we'll hold the debate and vote on our Good Government Initiative report. The program will begin at 11:45 a.m. in order to provide sufficient time for the debate and the vote, so please plan to attend and be here early to participate. That'll be here at the MAC. Club members, if you haven't already taken to doing so, make luncheon reservations online and receive your weekly bulletin via email. Just leave your email address with a staff member or call the club office. Anyone interested in obtaining a video or an audio tape of this or any other of City Club programs may do so through the club office. Videotapes are $20 and audio tapes are $10. Call Suzanne at the club office for more information. Our board host seated at the head table today is KATY King, member of the Board of Governors and Intergovernment Relations Liaison for the Oregon Health Services. She will have the privilege of asking the first question of Mr. Holmer. Following KATY's question, we'll open the program to questions from City Club members in the audience. Our time is limited, so please be ready at the microphone with your question. Please identify yourself as a member of the City Club and make your question brief and to the point, please. Broadcast of City Club programs this quarter is made possible in part by corporate underwriting from Portland General Electric, from CH2M Hill, and from Providence Health Systems, and we're very grateful for their support. Alan Holmer is President and CEO of the Pharmaceutical Research and Manufacturers of America, or PhRMA as they're known. His trade association represents all the pharmaceutical companies in America, with lobbyists in Washington, D.C., in every state capital, as well as in other parts of the world. Mr. Holmer is an Oregonian who went off to Princeton, then to Georgetown Law School, before serving as Chief of Staff to Senator Packwood. He practiced as a tax and international trade lawyer, served as a member of President Reagan's senior White House staff, and then was appointed Deputy U.S. Trade Representative with the rank of Ambassador. Since speaking to the City Club in 1984, Mr. Holmer has made frequent appearances on national television, generally immersed in controversies surrounding the pharmaceutical industry. I'm delighted to welcome you back and would also like to recognize your parents and other family members in the audience. Ladies and gentlemen, please welcome Alan Holmer.
Paddy, thanks very much. Thank all of you for the warm welcome. Who says you can't go home again? Actually, while I take great pride in the fact that I'm a native Oregonian, there's one fact that hasn't been entirely disclosed, which is I'm a little embarrassed to report that I was born in New York City. I lived there for 11 days, at which point my mother and I flew to, Portland and then to Salem, where my dad began a career at Willamette University and then on from there. But having decided to come to Oregon when I was 11 days old, I thought showed extraordinary judgment at a very young age. I'm also very pleased to be here with my mom and dad, Marcia and Freeman Holmer, with my brother and sister-in-law, Bill and Marcia Holmer, with my cousin Whitney, my cousin Will, and it's an honor for me to be here with you and with so many, I won't say old friends, but longtime friends, and an honor to speak at the Portland City Club. It's been about 35 years ago since I was in this complex in another capacity. It was the Saturday afternoon, after Thanksgiving in 1966, and South Salem was playing for the state football championship. South Salem had a great football team that year. We were ranked first in the state for most of the season. Among our stars was Craig Hanneman, who went on to play for Oregon State and then the New England Patriots. We were 10-0 going into the state finals, right over my shoulder in what I guess, Bill, used to be called Multnomah Stadium. And I learned a lesson that day that has been repeated countless times in my lifetime. However good you think you are, there's always somebody out there who is faster, bigger, and better than you are. That day it was Hillsborough, led by Dave Schilling, and South Salem was crushed 17-2. And as a member of the offensive line, the fact that the only points we scored were scored by our defense was especially insulting. But I hope to leave the MAC Club in far better emotional state today than I did 35 years ago. I'm going to put myself at some risk this afternoon by making an audacious proposal. I propose that we stop complaining about spending on prescription drugs. In fact, I propose that we cheer when pharmaceutical spending goes up. If somebody had predicted in 1950 that the average life expectancy today would be 77, that the Vice President of the United States would have an implanted defibrillator, in 1950 we would have asked, what's a defibrillator? That laser surgery would make eyeglasses obsolete for many. What's a laser, we would have asked. That hips, knees, lungs, hearts, and livers would be replaceable parts. That loading up on meat, cheese, and eggs would not be considered a formula for a long life. That we'd have medicines that could stop heart attacks in their tracks, and little blue pills that would make Bob Dole even more famous. The person who had predicted that in 1950 would have been considered a candidate for an insane asylum. But wait a minute. Thanks to innovative medicines, we don't even talk about insane asylums anymore. We've come a long way since 1950, and we're going further, faster. But we need to make sure that we take the right road. To illustrate why we should do this, let me paint for you two scenarios of the future. The first is an unhappy picture. Fast forward to the year 2050. Of the nearly 20 million Americans over 85, about half suffer from Alzheimer's disease, for which there is no cure. Most of them live in nursing homes, the fastest growing component of healthcare. With them are millions more seniors disabled by stroke, Parkinson's disease, congestive heart failure, and other diseases. In this year of 2050, healthcare expenditures are gobbling up GDP like rampant cancer cells. The government, which foots the bill for most nursing home care, has raised the top federal tax rate to 80%, abolished the Environmental Protection Agency and the Department of Education, cut funding for public transportation, airline safety, defense, and other programs. Family budgets, squeezed by the cost of maintaining parents and grandparents in nursing homes, can rarely be stretched to pay for college. The American pharmaceutical and biotechnology companies, once shining stars, have been reduced to a few companies that reproduce medicines invented back in the 1990s. I could go on, but I think you probably get the idea. Now let's look at a potentially happier picture. Thanks to the revolution in life sciences that began with the mapping of the human genome back in the year 2001, life expectancy has soared, but disability rates have plummeted. Alzheimer's disease has been relegated to the history books, and cancer has become a manageable disease, much like diabetes was before we found a cure for diabetes. Most nursing homes have been recycled into recreation centers and college dorms, some of them housing seniors who are using their added years of life to get advanced degrees. Hospitalization in this year 2050 is rare, since most diseases are routinely stopped by medicines before they do any real damage. Healthcare costs, once the Pac-Man that ate up government and corporate budgets, are now stabilized at a manageable level. And GDP is way up. The federal budget deficit has been eliminated. Since Medicare costs have stabilized, worker productivity is on the rise, sick days are on the decline, and most people are able to work into their 80s. Tough choice? More like what my 19-year-old daughter, Joy, would call a no-brainer. Funny thing about choices, they're not usually presented so starkly. More often we're faced with a series of incremental choices that have huge cumulative impacts down the line. In healthcare, we're in danger of making some bad incremental choices today that could lead to the disastrous scenario I described earlier. For example, just about every day, someone rises on the floor of the U.S. Senate or the U.S. House of Representatives to give a speech singing the praises of low-cost generic drugs and condemning the big pharmaceutical companies who invent, rather than just copy, medicines. Generic medicines have a very appropriate place in our healthcare system, but pending legislation would upset the delicate balance between generic medicines, between these two types of companies that this 1984 law achieved, tilting the seesaw heavily in favor of the copycats. Away from the companies who do the research, take the risks, go out on the limb, or go out on a limb because, as Mark Twain put it, that's where the fruit is. Now, many Oregon families have been profoundly affected by pharmaceutical innovation. My family is one of them. 22 years ago this spring, my wife and I learned that our baby boy, Scott, had cystic fibrosis. I suspect many of you followed the case of 19-year-old Brandy Stroder of McMinnville, who died earlier this month from cystic fibrosis while waiting for a lung, liver, heart transplant. My heart goes out to her family. In the case of my wife and me, I remember, like it was yesterday, the day we were told that our son had cystic fibrosis. I suspect Mom and Dad and Bill and Marcia, you remember it too. You were down in vacation in California when I called. But in March of 1980, our doctor, Robert McDowell, called us in and began what was clearly going to be a careful, sensitive, detailed explanation of what cystic fibrosis is all about. I couldn't take it. I stopped him and I said, "Doctor, is it going to kill him?" And Dr. McDowell paused, looked down, and said, "Eventually, in all probability, yes." Later on, we learned some things that were even more discouraging. We learned that when children with cystic fibrosis die, that it's a long, lingering, painful death. Essentially, these children suffocate to death. Imagine contemplating that for your child. The experts we consulted and the books we read, they were as good as they could possibly be. But they were wrong in at least one respect. The experts had told us that our son would likely die by the time he was 18. And they were wrong in making that prediction because they hadn't counted on the brilliance, the tenacity of the resources and the research of the American pharmaceutical industry. They hadn't counted on the antibiotics our companies have since produced, and they hadn't counted on a devoted young scientist named Dr. Stephen Schack of Genentech, located in San Francisco. Dr. Schack joined Genentech in 1986, just about the time the company was coming out with their new stroke medicine, TPA. As many of you know, TPA helps to break down the blood clots in arteries in order to be able to help prevent heart attacks. Like any great scientist, Dr. Schack asked questions. He said, you know, if we can come up with a natural protein that can help break down the blood clots in arteries, why can't we come up with another natural protein that will help break down the thick and sticky mucus in the lungs of children with cystic fibrosis? The result of his questions and hard work was a wonder drug called pulmozyme. Pulmozyme helps to liquefy the mucus in the lungs of children with CF so that germs don't get trapped there, so they can breathe, so they can live. So 22 years ago this spring, the experts told us that our baby boy was likely not to live past 18. Well, I'm pleased to be able to report to you that last December, our son's pulmonary function was 102% of normal for 22-year-old males in America. Scott will graduate next month from Georgetown University with a double major in English and theology. Like his mother, he's decided to devote his life to teaching. Are Scott's medicines expensive? You bet. Fortunately, like most Americans, he has insurance coverage. But the cost of his medicines is counterbalanced by other huge savings to the healthcare system, including the fact that he doesn't have to go to the hospital anymore. Now, maybe our healthcare system would save money if Scott didn't have access to the best medicines and he were no longer alive. But that's a result that is just too horrifying for any father to contemplate. How do you put a value on his life? Or the life of his little sister, Joy, who also has cystic fibrosis, but is a healthy, happy college freshman at Westmont College in Santa Barbara. And while this is a good news story thus far for my children, we don't yet have a cure for cystic fibrosis. There is no doubt in my mind that a cure for cystic fibrosis will be found. But my life's passion is that a cure for cystic fibrosis will be found within the lifetimes of my children. And I believe that cure will come more quickly if we keep intellectual property protection strong, and if we keep all of the signals to investors in pharmaceutical research strong. You know, people's eyes glaze over when you talk about patents and intellectual property rights. But if you're a patient with a life-threatening disease, or a dad waiting for a cure for a life-threatening disease, you want strong intellectual property protection. My bigger, wiser, older brother taught me long ago that if you create incentives for things, you get more of them. If you create disincentives for things, you get less of them. That applies to pharmaceutical R&D just as it applies to everything else. We need to make sure that incentives for pharmaceutical innovation remain strong. Without strong intellectual property protection, will pharmaceutical companies continue to invest the $800 million a year, will they continue to invest $800 million, the cost that it takes to get one new medicine to market, knowing that they only have a 1 in 5,000 chance at success? Will the industry as a whole continue to invest over $30 billion a year on research and development? To make that kind of investment, a company needs to know that it will be able to sell its product for a reasonable amount of time without somebody else being able to come along and steal their idea. Without patents, most of the medicines in your medicine cabinet just wouldn't exist. And to recognize the challenges facing the pharmaceutical industry, just read the headlines over the past few weeks. New York Times, April 8th, about the pharmaceutical industry, quote, "Innovate or die." Or the Associated Press on April 7th, quote, "Growth gets tougher for drug makers." Despite the huge challenges of pharmaceutical innovation, policymakers are infatuated with the lower price of generic drugs. But without the medicines invented by pioneer companies, today's generic drug industry wouldn't exist, because these copycat companies do precious little research of their own, and they do zero research on medicines for such rare diseases as cystic fibrosis. So if we want to maintain the status quo, if we're perfectly satisfied with state-of-the-art medicine today, generics are clearly the way to go. If instead we prefer progress and new cures and treatments, then we need to keep the incentives for innovation strong. Let me give you 400 reasons why. Research-based pharmaceutical and biotech companies are currently working on more than 400 medicines for cancer. Ask the generic companies what they're doing to cure cancer. They'll probably change the subject. Small wonder that physicians who value having innovative medicines to treat their patients come down heavily on the side of strong intellectual property protection. In fact, a recent poll found that 2 out of 3 of the doctors surveyed believe that weakening patent protection will hurt the search for cures. And 3/4 of doctors view patent protection as very important to the discovery and development of new treatments that patients need. Policymakers have raised a hue and cry over rising prescription drug expenditures, even though medicines account for only about 9 cents of the healthcare dollar. Let me repeat that. Medicines account for 9 cents of the healthcare dollar. It's true that the percentage of drug spending is inching up, and some see that as a problem that calls for weakened intellectual property protection or price controls. In fact, our governor here in Oregon has called for price controls on pharmaceutical manufacturers, which would harm biomedical innovation and discourage future biotech and pharmaceutical investment in Oregon. Concerns about increases in drug spending are based on the conviction that the different sectors of the healthcare expenditure pie should be stagnant, that we should allocate the same percentage of resources to each sector year after year, even though there are different rates of progress in different areas of healthcare. But why should we forever allocate our resources to fit the patterns of the past? If that were the right thing to do, businesses would allocate the same percentage of their budgets to messengers and secretaries as they did before computers and email. And the U.S. Army would be spending the same percentage of its resources on cavalry horses as it did during the Spanish-American War. Medicare provides a good example of the failure to change the reallocation of your resources to fit the times. Medicare, of course, covers hospital care, but it generally does not cover the cost of medicines that can keep people out of hospitals and nursing homes. That simply has to change. The #1 priority of America's pharmaceutical companies this year is to press Congress to enact a prescription drug benefit. We want seniors and the disabled to have access, now and in the future, to life-saving, life-enhancing medicines. Senators Ron Wyden and Gordon Smith have an excellent proposal that moves in this direction. And I commend them for the fact that one Democrat, one Republican are working together closely to try to be able to achieve common ground on this issue. One example of the importance of access to medicines is cholesterol-lowering drugs, which cost billions of dollars, but which have proved to be highly cost-effective for many patients and have contributed to the improved life expectancy and better functioning of Americans today. Of course, we could reduce spending on prescription drugs by eliminating access to the cholesterol-lowering medicines that pharmaceutical companies invented, or by changing the rules so that the next dramatic advance in medical care never arrives. If we did that, the share of the healthcare dollar spent on prescription drugs would drop. But at what cost to society? Should we squelch medical progress because some bean counters are nostalgic for the good old days, the so-called good old days, when we were spending less on prescription drugs? Let's take a hard look at those good old days and figure out which year we'd like to go back to. How about 1980? In 1980, we were spending not 9 cents of the healthcare dollar on prescription drugs. We were spending less than 1 nickel out of every healthcare dollar on prescription drugs. But if you had a heart attack in 1980, your family could start planning your funeral. There were no clotbuster drugs that routinely save the lives of heart attack patients today. In 1980, nearly 300,000 Americans died of heart attacks. By the year 2000, that number had been cut by more than 1/3. And if you opted for the status quo in 1980, you'd also be missing state-of-the-art antidepressant drugs that we have today and the medicines that enable children who get leukemia to survive 8 times out of 10. Well, maybe 1980 isn't the right year. Let's try 1990. In 1990, prescription drugs represented not 9 cents of the healthcare dollar, only 6 cents of the healthcare dollar. Maybe that'd be a good thing to do. But there were no protease inhibitors in 1990, no combination therapy for AIDS. A diagnosis for AIDS was a virtual death warrant. Since combination therapy for AIDS was introduced in the mid-1990s, the US death rate from AIDS has dropped by nearly 80%. And if you opted to freeze medical progress in 1990, you wouldn't have the drugs that prevent nausea in chemotherapy patients, or the medicine that puts hairy cell leukemia patients in remission after only 7 days of treatment, or the medicines that reduce the frequency and severity of attacks for MS patients. And my children wouldn't have the Pulmozyme from Genentech or the Toby, a medicine made by an antibiotic produced by pathogenesis in Seattle that have been discovered and brought to market just since 1990. So maybe not 1980, maybe not 1990. Maybe we go back to 1997. Back then, we were spending only 7 cents of every healthcare dollar on prescription drugs. The bean counters might settle for that, but I doubt if Maggie Lutz would. Who's Maggie Lutz? Maggie is now a healthy 23-year-old grad student at the University of Illinois, but she was one of the almost 1,000 people a day who die of severe sepsis. 4 years ago, Maggie arrived at the emergency room at the hospital in the city where she was attending college. She arrived there weak and disoriented, with kidney and lung failure, large purple blotches all over her body, bloated beyond recognition. The prognosis? A 10% chance of survival. Fortunately, the emergency room doctor knew about an experimental drug for sepsis that had been tested by Eli Lilly and Company. He called the folks at Lilly, and that same day, a company employee flew the medicine to the hospital, pleading with the pilots to fly in spite of raging thunderstorms. By 10 p.m., Maggie received the first dose of the medicine. 4 days later, she regained consciousness and was on her way to a complete recovery. Just last year, the medicine that saved Maggie was approved by the Food and Drug Administration. Good news for anybody who gets sepsis, but a cause for hand-wringing and nail-biting by some policymakers who seem to view breakthroughs in medicine not with awe, but with alarm. Because if there are wonderful new medicines available, patients will want them, and doctors will prescribe them, and soon we may be spending 15 or even 20% of our healthcare dollars on prescription drugs. By spending more upfront on research-intensive products such as prescription drugs, we're actually saving money down the line. Mom, it's like what you told me 45 years ago. An ounce of prevention is worth a pound of cure. For example, a pill that costs less than $3 a day, about the price of a latte in Starbucks, can lower your cholesterol. It could save you from the experience of having your chest cut open and your heart stopped while surgeons reroute your arteries. That operation will cost as much as $75,000, and you'll spend several months recuperating. Another example, medicines that can prevent osteoporosis in older women cost about $730 a year. If we can prevent osteoporosis, we can also prevent a large number of hip fractures, which cost an estimated $41,000 per patient and often lead to nursing home admission. If you have a stroke today, I've talked before about TPA, you can have a clot-busting drug that may be able to save you from the disability and indignity of permanent brain damage. It's true that the medicine is expensive, but the National Institutes of Health has found that by eliminating and reducing the cost of hospitalization and nursing home care, the drug nets an average savings of more than $4,000 per person. NIH also estimates that greater use of this medicine would save about $100 million a year. And a study by the Columbia University economist Frank Lichtenberg found, on average, that an $18 increase in drug spending resulted in other healthcare savings of $71, or a net saving of $53. I respectfully suggest that Governor Kitzhaber and other healthcare policymakers in Oregon carefully consider these facts about the value of innovative medicines. I think that if they looked at the value of medicines to patients and not just their short-term cost, they'd be far more likely to give Oregon patients with very little resources access to the best medicines. As many of you know, Governor Kitzhaber, undoubtedly very well-intentioned, proposed last year to reduce drug costs by imposing restrictions on what drugs would be available to Medicaid patients, the poorest and most vulnerable of Oregon citizens. Under the governor's plan, these patients would be denied access to the best, most innovative medicines, the medicines that doctors think work best for them. We believe this would be cruel to the individual patients involved and the wrong way to go for Oregon and for the country. Fortunately, the governor's original proposal has been substantially modified. Poor people are deprived of lots of things, but for the good of our society, as well as for the sake of those individual patients, they shouldn't be deprived of the miracle of modern medicines. Oregonians should look at the experience of other states that have restricted the access of Medicaid patients to prescription drugs. In Maine, an elderly woman suffered internal bleeding and ended up in an intensive care unit after the state switched her to a cheaper drug for her stomach pain. In Florida, a man died of congestive heart failure at 60 after his doctor unsuccessfully tried to get the state Medicaid system to get him the drugs he needed to stay alive. In Mississippi, a man died of pneumonia because Medicaid wouldn't pay for the $45 antibiotic that might have saved him. Instead of spending $45, the state wound up with a hospital bill of $4,900 and a dead patient. I understand the severe financial problems that our state is wrestling with. America's pharmaceutical companies are eager to work with the governor and others to solve these problems. But we will never relent in our opposition to proposals that would deny patients access to the medicines they need to stay alive and well. In Oregon and everywhere else, we need to put our healthcare dollars where they can do the most good, based on scientific data about how to achieve the best health outcomes. We need to look at the value of treatments, not just their short-term costs. And we need to encourage the innovation that will lead to cures and one day eliminate such diseases as Alzheimer's. The potential burden of Alzheimer's disease to our society is huge, unless a pharmaceutical or biotechnology company comes up with a cure. But what about the personal burden to you, to me, to each of us in this room? Fast forward to your own 85th birthday. I assume everyone in this room would like to live at least to 85. Nearly half of all Americans over 85 today have Alzheimer's. Will we change that grim statistic? Or will half of us who are here today be celebrating our 85th birthdays in nursing homes? In large measure, the answer will depend on the choices we make about the healthcare issues we face today. On behalf of America's pharmaceutical industry, but more passionately, as a dad waiting for a cure for a deadly disease, I pray that we choose wisely. Thank you very much. I guess I'm told I stay here for the questions, but I'm also told KATY has the first one.
Mr. Holmer, if you were governor of the state of Oregon and Oregon health plan costs for prescription drugs were reaching in the neighborhood of several $100 million a year, what would you ask the CEO of PhRMA to do to help bring down drug costs for the state? And secondly, can you discuss some of the benefits of having the state use an evidence-based process to identify effective but less costly drugs for Medicaid clients?
I'm sorry, repeat the last one again.
Can you identify some of the benefits of having the state use an evidence-based process to identify effective but less costly drugs for Medicaid clients?
Right. Leave them up here, both of you. Sorry. That's great. Katie, thanks. Bill, whatever happened to foreplay? First, I'll drink some water while I think. You know, when I was growing up in Salem, that was my goal in life. My dad was state budget director for Mark Hatfield when he was governor, and my goal in life was to be governor of Oregon. So, at least for 3 minutes, I have that opportunity now. So I'm Governor Holmer, and I'm speaking to the chief executive officer of that trade association representing all those pharmaceutical companies. And what I would say to him was, I'd get him on the phone right now and see if he could come down to Salem sometime this weekend. And he'd say yes. And I would then want to say, okay, I hear what you say with respect to the value of your medicines, and it may very well be that as you increase cost for prescription medicines, overall health care costs go down. And I take your point that we need to stop focusing just on silos. Don't focus just on, I'm going to get the answer to the question, don't focus just on hospitals and doctors and nursing homes and prescription medicines. And I hear you on all of that, and I buy into your argument. But I have a huge fiscal problem in my state, and won't you come please help me with all the expertise you have in the pharmaceutical industry and elsewhere to try to help us solve this problem? That's what I would say if I were the governor. And what I would say if I were the head of the trade association representing the pharmaceutical industry, which I am, I would say, yes, sir, Governor, we will have the best experts possible that will be on your doorstep tomorrow morning or next week or next month, whenever you want. Because as I said in my remarks, we want to be able to help Oregon and other states to be able to address these problems. And I think what needs to be done is to have the state of Oregon and other states be able to use the same kind of mechanisms that are being used increasingly by private sector health plans, where they look at creative things like disease management and case management. Disease management where you look at diseases where there are particularly high levels of chronic problems, be it congestive heart failure or diabetes or asthma, and focus on those with intensity and find creative mechanisms to be able to sometimes use more medicines, but be able to address those more effectively. I think there is, we have met with people from Accenture and the McKinsey Group on ideas that they have as to how they can help states bring down Medicaid costs. I believe it can be done, and Mr. Governor, I want to do everything that I can to be able to make sure that that happens. Now, question 2 was, and I thought you just got one question, Katie, but question 2 was, the legislature enacted a bill, purpose of the plan to help enrollees with the most effective drugs at the best price. Pharmaceutical lobby was opposed to this bill. Why is PhRMA opposed to the state using an evidence-based process to identify effective but less costly drugs for Medicaid clients? And I guess there are several concerns that we had there. One, the original proposal said that a bureaucrat, and Dad, I love state bureaucrats. I lived in, I grew up with one, but you'd have an individual government official who would make a decision as to, not a doctor necessarily, but would make a decision about what's the most cost-effective or most effective medicine. And the example that's used is if you have arthritis pain, it would be ibuprofen, it wouldn't be Vioxx or Celebrex. And if and that would establish the so-called reference price for the medicine. And if it turns out that the cost, that your doctor says you need a different medicine, and you go through various hoops, if you need a different medicine, the cost of the original medicine is here, and the cost of the more effective, more innovative, more newer, medicine would be more expensive. The difference between the cost of the reference price drug and this more expensive drug would be paid for by the Medicaid patient under law. To us, that didn't make any sense. Why should you saddle Medicaid patients with that kind of cost? We believe it's far more effective not to look solely at the drug budget, but to look at all aspects of health care on an integrated basis, and then on that basis, use some of the mechanisms that we've talked about with respect to disease management and look at improved ways to be able to do this under Medicaid programs. And I was told by Jim Gardner, who was our counsel here in Portland and in Salem, that the legislature indeed passed a bill that included many of these kind of components, but that ultimately was vetoed. And we think those kinds of proposals are the ones, Mr. Governor, that it would make most sense for you to focus on in areas going forward. Next question.
Greg McPherson, City Club member. I've spent the last 3.5 months going door to door in a campaign for the Oregon House of Representatives. And one of the recurring concerns that's been expressed to me on the doorstep is about the disparity in price between the name brand drugs here in the U.S. and abroad, particularly in Canada. And I'd like to have you comment on that disparity. Does it exist? And if it does, then does that suggest that American consumers are subsidizing disproportionately the research and development that then spreads abroad?
Well, it's a very good question, and I'm one that I suspect resonates here in the room. The latest numbers I have seen show that as a percentage of gross domestic product, Canadians spend precisely the same percentage for their pharmaceuticals as we spend in the United States. Let me state that again. As a percentage of gross domestic product, Canadians spend exactly the same percentage as we do for prescription medicines. Now, let's make sure that I'm in full disclosure. I'm sure that Bill helped me with this. The GDP in the United States is higher than the GDP in Canada for a whole bunch of reasons, and therefore that percentage for prescription medicines is somewhat higher. But Canada has a deliberate policy of price controls on the newer, more innovative medicines, and having higher prices in Canada than what we have with respect to generic medicines. I was at dinner last night with a doctor whose parents were from Canada, and he told me that he has relatives who come to visit him in Washington State so they can come to buy cheaper generic drugs in the state of Washington, because generic drugs are priced too high in Canada. Now, it's true. Canada does have price controls for their products, and sometimes for the newer, more innovative medicines, those products cost less in Canada than they do in the United States. But believe me, and I may address this particularly looking Congressman Wu at you, we don't want to adopt the Canadian healthcare system with its price controls, with its long waiting lines, with all the other problems that they have in their system. And let me give you one very specific example that really touched me to the core. As I mentioned earlier, my son takes this aerosolized spray called Toby. It's quite expensive, and it's made by Pathogenesis Corporation up in Seattle. And I didn't realize this until last night, but in British Columbia and in the vast majority of provinces in Canada, they don't reimburse for Toby because it's a wonderful, new, innovative medicine that is also expensive. Is that in the interest of patients with cystic fibrosis? My son, because of that medicine and because of pulmozyme, and because he runs a lot, he's at 102% of normal for his pulmonary function. cystic fibrosis patients in most provinces in Canada are denied that. And the other thing I'd ask you, well, two other things with respect to the price disparity. Check what the value of the Canadian dollar is compared to the US dollar. Ask yourselves, except for generic drugs, is there anything that is less expensive in the United States compared to what it is in Canada? And you'll find that to a very great extent that everything, almost all things, are less expensive here than they are in Canada. So I think that'd probably be my answer on that question. Next.
Bill Savage, member. One of the calls I hear on the radio a lot for less costly prescription drugs has to do with the AIDS crisis in Africa. And I wonder if you would comment on that and what the pharmaceutical industry is doing in regard to that.
An excellent question. Clearly what is happening in Africa, especially sub-Saharan Africa, is a catastrophic tragedy of unimaginable proportions. And pharmaceutical companies have stepped forward in many ways. One, they made the investments. I know some companies that invested over $1 billion to be able to find a medicine for AIDS. And they have, many of them have made medicines available in Africa for free or at cost. But even if they say we're going to make these available only at our cost to be able to manufacture the product, none of the R&D or anything else, just at the cost to be able to manufacture the product, it is still too expensive for the companies to be able to afford. And therefore we need to have a global AIDS fund that will help those countries to be able to purchase those drugs. But even more importantly, if you were to take a helicopter full of medicines and took them and left them on a dock in whatever the country is that you would identify, we have a huge problem with respect to infrastructure, healthcare infrastructure in those countries, where there are too few doctors, too few clinics, and we need, I think, as a civilized worldwide community, to be able to do more to be able to help those countries. The pharmaceutical industry is doing, I think, is doing its part. We will be doing more, but it is a problem that goes beyond the capability of the pharmaceutical industry solely to be able to solve on our own. And our companies are also working intensely on being able to come up with a new vaccine for AIDS and for better treatments. I'm particularly concerned about the extent to which the current regime of AIDS medicines have worked so far, but there are now more and more drug-resistant strains that have developed, and we need to be able to find a way to be able to combat those as well. Next question.
Steve Gregory, member of City Club, and to a certain extent I'll be devil's advocate.
Sure.
On the one hand, I worked 33 years in the pharmaceutical industry, marketing management, 2 large major international companies. And from that point of view, I certainly can understand the arguments you make for research, patent protection, etc. On the other hand, I'm a member of City Club's healthcare committee and working in long-term care facilities where there are major concerns, as everybody knows, about the price of pharmaceuticals. So I can certainly see that there is somewhat of a problem, and it's a big one. When I was working in the industry, that was up to '93, the major portion of marketing expenses was always the cost of the medical representatives, the detailers that went out and gave the story of their products to doctors to educate them on prescribing. Now I understand that that's changed drastically. The major cost of marketing is TV advertising to the public, trying to get prescription drugs prescribed by the doctor at the patient's request. My question is, has this question come up seriously before the industry as maybe a problem they should readdress reconsider, even though they're allowed to advertise, it's costing too much in the price of the final product. I would just like to have your comments on that subject. Thank you.
Thank you for the question. Let me try to put the numbers in perspective. Last year, the pharmaceutical industry spent over $30 billion on research and development. And the industry spent about, don't hold me to these numbers precisely, but these numbers are roughly accurate, about $15 billion on marketing, most of that being to physicians. And the marketing there breaks down, it is about $8 billion in free samples to physicians, which physicians are often able to use then to be able to provide medicines for people that can't otherwise afford them. There is about $6 billion in what they call the detailing, that is, letting physicians know about new cures and treatments. The pharmaceutical industry has just come out with a new marketing code where the companies that sign up for it, and I suspect the vast majority of them will, where it does place some parameters around those marketing practices. But the number for direct-to-consumer advertising for last year, independent data, is $2.5 billion. Over $30 billion for research and development, about $2.5 billion for advertising. Some of that print advertising, you see it in Parade magazine, but other parts of that advertising on TV. Is that a good thing or is it a bad thing? I'd submit to you that it's a good thing, and here's why. We have a huge problem in this country with respect to undertreatment and underdiagnosis of disease. If, when you left this room, if you call the American Diabetes Association in Washington, D.C., they will tell you that there are 6 million Americans who have diabetes and who don't know it. 1/3 of all the people in this country who have severe depression never seek treatment for it. And there are millions of Americans who have high blood pressure and don't seek treatment for it. So the more information that we can get out to patients that will allow them to be able to begin a conversation with doctors about new potential treatments or cures that are available for them, I think the better off those patients are going to be and the better off our healthcare system is going to be. Let me just give you one final example. I talked about Bob Dole and the little blue pill. What we find is that one of the biggest health challenges that we have is that men don't go to the doctor as often as they should. And what has happened, there have been, no surprise, over the last few years, millions of American men who have, some induced by direct-to-consumer advertising, some didn't need the advertising, to go in and talk with their doctor about the fact that they'd like to be prescribed Viagra. And the doctor will say, well, I can't do that immediately. We need to do some tests. You would be amazed at the percentage of the time where that doctor says, you know, you don't need Viagra, you have diabetes, you have heart disease, you have prostate cancer. So to the extent that these direct-to-consumer ads induce patients to go in and have a more informed conversation with their doctor, I think that's good news for those patients. Next question.
Mr. Holmer, the drug Claritin sells for $2.13 a pill in the United States and 70 cents a pill in Canada. Schering-Plough, which manufactures Claritin, in the year 2000, according to SEC reports, spent 14% of its money on research and development, but had profits equal to 25% of revenues. When an FDA advisory panel concluded that Claritin should be sold as an over-the-counter drug, Schering-Plough insisted that no, it should remain a prescription drug, where they could continue to charge higher prices. What do you say to those who think that the Claritin story indicates that something is rotten in the state of Denmark?
Let me just talk, I think, generally about the subject that you've raised. The specific details with respect to Schering-Plough and Claritin, I think I'm not going to be able to get into those. I do know that there's an organization here that has passed out a document for people who came in. I see it as an open letter to the City Club of Portland, and it presents some numbers to the extent that you have them are very misleading. They show that they talk about research and development by pharmaceutical companies, and then the amount that's spent on marketing and advertising. And what you often hear is that companies spend far more on marketing and advertising than they do on research and development. And I'll show you why these numbers are so very misleading. What they don't tell you is the numbers they're not for marketing and advertising. They're for marketing, advertising, and administration. And as my dad, the former director of the Department of Finance and Administration in Oregon, will tell you, there's a lot of dollars that go into administration. They also take data that says the percent of revenue allocated to research and development. And they take the company, let's take the first one on the list, Merck & Company, where they say Merck spends 6% of its revenues on R&D. Now, I hadn't yet said this, but I would have told you that the pharmaceutical companies spend on average close to 20% of their revenues. They plow back close to 20% of their revenues back into R&D. Well, how can this possibly be that Merck's percentage is 6%? Well, it's because those who presented this table were trying to trick you with the numbers. Merck & Company includes as a major subsidiary Merck Medco, which is a pharmaceutical benefit management company from which many of you may get your pharmaceuticals. And if you include Merck & Company plus their huge subsidiary, Merck Medco, with all of its sales, and say, well, what percentage of their total revenues is R&D, you're going to get a much, much lower percentage. So I think we need to consider all of the situations with respect to the percent that's being spent on R&D in the context of what the numbers really are. Now, with respect to the specific issue of pricing comparisons on Claritin US versus Canada, I've had a chance to talk a bit about that. As it relates to whether or not that product should go over the counter, that's a specific issue to be made by the Food and Drug Administration, where Schering-Plough has been engaged in that discussion, and I'd probably leave it for them to have a chance to respond to that further. Next question.
This will be our last question. Oh, thank you. Paul Milius, club member. Do you see that the current inflation of advertising of all kinds of prescription drugs, along with the ongoing advertising for over-the-counter drugs, creates a mindset in this country that drugs are okay, that to feel good, you need to just take a pill, take a drug, what have you, particularly influencing the thinking of young people in terms of slipping over into the illegal drug area? It's okay to feel good, you take a drug. First question. Second, would you support, or does your organization support, the same kind of aggressive policing tactics to handle the increasing diversion of substantial supplies of certain prescription drugs, painkillers and what have you, into the illegal drug market? I mean, if you want to buy OxyContin, if you ask around, you could probably find it on the street. So it's a two-part question about that. The advertising, does that create a mindset? And secondly, does your organization support very aggressive tactics like seizure of assets and informers and so on to suppress the diversion of drugs to the illegal trade?
Yeah, what I'd like you to do on the second question, if we can follow up later on, let me have a chance to get your card, and I'll respond very specifically on that. In general, our industry does want to be able to work with legal authorities and others to be able to address those kind of situations, because it makes no one wants to have a circumstance where you have a medicine like the one that you described gets into the hands of the wrong of people who either organized crime or others, where they're going to be using that medicine inappropriately. With respect to the mindset, I think you raise a very valid issue and question. And I think very frequently in conversations that I have, or the speeches that I give, or in communications that any of us have with our doctor, I know I've had those conversations where I've suggested to my doctor, you know, is it time for me to get on the cholesterol lowering medicine? And he said, well, maybe we ought to take a year and see how you do with more exercise and less fatty foods and the rest. And after we gave it our best shot, and I did what he told me to do, and I still needed to get my HDL up, we decided that it makes sense to do it. But I think you're absolutely right. The medicines that have been provided are wonderful, and we should not discourage people from taking those, but we also need to recognize that there are many other steps that people can take on their own independently that people probably should attempt to do first before they go with a prescription medicine.
Well, thank you very much, Mr. Holmer.
Thank you.
That's been a splendid presentation. We are adjourned.